My name is Dr. Ian Storch. I'm a board-certified gastroenterologist and osteopathic physician, and you are listening to DO or Do Not. If you are interested in joining our team or have suggestions or comments, please contact us at doordonotpodcast.com. Share our link with your friends and like us on Apple Podcasts, Facebook, Twitter, and Instagram. We hope you enjoy this episode.
Can a DO be a surgeon? Can a DO be a breast surgeon? For the answers to this and more, listen to this episode of DO or Do Not. Dr. Sogunro, thank you so much for being with us tonight.
Thank you so much for having me.
So we're so excited that you are coming from Johns Hopkins, which is an amazing university, and that you're awesome, and that you're a breast surgeon, and that Carissa Champion thinks you're great. So all of those things make us super excited to interview you tonight.
Well, thank you so much for having me. Pleasure to be here.
So can you start by just pronouncing your full name for us, for anyone who's reading it online and is like, she's awesome, but I can't say her name.
Dr. Olutayo Sogunro.
Awesome. And I'm not going to say that 3 times. We're just going to jump into things. Can you tell us what is a breast surgeon and really what your scope of practice is?
A breast surgeon is someone who takes care of breast disease. So I'm a breast surgical oncologist. So I have fellowship training in breast surgical oncology. So really, majority of my practice is just breast patients. And within that practice, majority of those patients are breast cancer patients. So these are patients who've been diagnosed with really any stage of breast cancer, or even patients who have high risk lesions, so don't necessarily have breast cancer, but are high risk patient, or have a lesion or have been diagnosed with something in their breast that may not be a breast cancer, but has a high chance of becoming breast cancer in the future. So I take care of both breast cancer patients, which is majority of my practice, as well as high risk lesions, as well as high risk patients, and also other masses in the breast that are not cancerous that also oftentimes need to be surgically excised.
So if a patient was a high-risk patient, let's say they have a family history, they're BRCA positive, maybe a young woman come to you and talk to you about prophylactic mastectomy or having their breasts removed, let's say, and even if they decide not to do it, would they still follow with you or they follow with their primary? How do those type of cases work?
That's a great question. So associated with most breast cancer centers and breast clinics like ours is a high risk program. So those patients are really going to be high risk for their life, right? Even if they have a genetic mutation, they decide not to do a prophylactic mastectomy, then they still need to be followed with high risk screening. And a lot of those things are managed through following with us in our high risk breast clinic. So those patients, for example, if they were diagnosed with a particular genetic mutation, a germline mutation like BRCA1 or BRCA2, as well as many other genetic mutations that we have identified, those individuals would undergo high risk screening starting at age 25. That oftentimes includes starting at age 25 with breast MRI, and then at age 30, we add annual mammography to that. So those patients end up often in each year with a mammogram and an MRI. So that would be part of the high risk screening protocol that would be managed in a high risk breast cancer program like ours.
It totally makes sense because for primary care or even somebody specialist, a medical specialist in breast disease, it's probably hard to get those things authorized and have the insurance companies understand the importance of those things.
That and really just even managing the schedule. I think one of the big things that ends up happening in primary care is there are a lot of things that the primary care physician is having to manage, and knowing at what point should they be sent for this, or at what point should, for example, the patient maybe get genetic testing, at what point should this happen. Some of those things, those are guidelines that we work on and work with every day. So to ask someone that's not necessarily the specialist to do that, sometimes it's tough. It also depends on where the patient lives and what access that they have, right? Not everyone may have access to a breast cancer center or a high risk center. So a lot of those things can be managed in primary care, but in terms of long-term high-risk screening, that's something that most breast centers can definitely manage. So I just recommend people looking into high-risk breast screening programs.
That sounds great. That sounds like very good advice. So let's say as a medical student listening or a medical resident listening, and they're thinking about a surgery path, why should they think about being a breast cancer specialist or doing a breast fellowship? And are those competitive?
Really, surgery in general is relatively competitive. I would say actually almost any specialty is competitive, right? Medicine is not easy. And so anything in medicine, I think, is relatively competitive. And surgery is really something that you want to make sure that it's what you want to do, right? It's not something that's fun and cool. I always tell people avoid what I call those sexy careers, right? That
I
look
thought
really good, but then, as they age, is it also going to look great when you age? So always keep that in mind because this is something that you're going to be doing for majority of your life. Majority of our life is spent working. So if you're going to be doing something, it needs to be something that you're going to love because it's going to be majority of your life, right? And then in terms of within that, once you've made that decision to, okay, medicine versus surgery in terms of specialties, then you try and decide within surgery, what are the things that interest me? So some people, if you really like to work with obviously joints and bones and power tools, then obviously orthopedic surgery would be a great fit. If you love to work in the abdomen and love kind of that variety every day, then general surgery would be a great fit. So you have to kind of determine where your niche is going to be. And then within that, you want to determine what are the things or the aspects of that specialty or subspecialty that bring you joy. So for me, particularly with breast cancer surgery or breast surgical oncology, it's the oncology aspect with the surgery aspect. These are long-term relationships that you develop with the patient because cancer is not just a one and done, it's a lifetime, really disease management. So I'm going to be working on diagnosing the patient, doing their surgery, but also in the aftercare and in the long-term management or what we call survivorship, breast cancer survivorship. So being integral in their care throughout the whole process is really important to me. Other surgical specialties, it really depends on which one it is, but oftentimes it's diagnosis, treatment, and in the short term, obviously there will be some follow-up, but not necessarily long-term follow-up, right? I'm seeing patients 6 months later, a year later, then another year later after that. In breast cancer patients, surveillance, so that portion of care that happens after your surgical treatment, usually is anywhere from 2 to 5 years, if not lifetime. We do try and let people go eventually when we say to them, hey, you can follow up with your gynecologist or your PCP after 2 years or 5 years. But oftentimes, patients are like, no, I'm going to see you forever. So that happens too. But for the most part, you're going to be developing a 2 to 5 year relationship with these patients. So I think wanting that as part of your practice is important because a lot of people may not want that. And if you don't want that, then maybe it's not the right fit. But these patients are going to be yours for a really critical time in their lives, a transformative time in their lives, and for a long period of their life. So for me, that's a part that was important, developing those long-term relationships with patients and really just feeling like I am a partner in their care and walking through them. I get to see them when they first find out, which is tears, sadness, all that emotional baggage at the initial diagnosis. And then now some patients, I'm seeing them a year later, 2 years later, new hair, new chest, new breasts, right? They're a different person. So really getting to see that evolution of patients is beautiful to me.
That is amazing. That is the best answer I think I've ever heard. And I would never imagine hearing that from a surgeon. That's more of like a medical doc, family practice type answer from a surgeon, which I think is absolutely spectacular. And I think anybody interested in surgery should listen to that because I think you make a great argument for why somebody should consider the specialty. I mean, it sounds like I want to be a breast surgeon now. I'm a little
Come on down, we'll have you.
a
Come
little
on.
too old, too old. So tell us a little bit about what your regular workday looks like. What time do you wake up in the morning? Can you take us through your roles and responsibilities through the day? And maybe even tell us about some cases that you did yesterday or this week or patients that stand out in your mind.
So a typical workday in at least for a breast cancer surgeon or a breast surgeon involves a mixture of clinic and or OR. So depending on which day of the week it is, generally our weeks are broken up into about 50% OR and 50% clinic. which is really a lot more than a lot of other surgical specialties, where a good chunk of their week is going to actually be operating. And ours is close to 50-50, if not 60-40. So I do spend a decent amount of time in clinic because, again, as you know, I have to diagnose a patient and work them up and discuss their disease process with them. So that's where a lot of those connections and relationships begin. So one portion of my day will be spent in clinic where I'm doing consults. A patient was diagnosed with breast cancer maybe a week or so ago or a few days ago. They had their biopsy that was proven positive, and then they're going to come in and see me. So I usually, other than the radiologist who did their biopsy and called them to say, hey, that biopsy that we did, it came back with cancer. Here's a referral to see a breast surgeon. Other than that phone call that is terrifying and pushes people almost to the edge, I'm the next person that they see in terms of physicians. So I see that patient and I'm going to explain to them, this is what your diagnosis is and this is what we need to do. Really ends up being walking people off the ledge because between that 1 week, 2 days, 3 days, whatever it is that they've received that diagnosis to seeing me, they have doctor Googled their minds out. Okay. And so people have said, they've started writing their wills, they've started saying their goodbyes and all those things. So the first portion of my week often starts in clinic where I'm going to be talking to the patient and diagnosing and doing any additional workup if we need to order some additional imaging, some additional biopsies, etc. Then a portion of my day will be spent in the operating room where that patient that was diagnosed with their breast cancer, I'm going to be taking them to the operating room for, a lumpectomy or a partial mastectomy or a mastectomy. And my responsibilities really are diagnosis, treatment, and management, including the surgical removal of their breast cancer, whether it's their whole breast or a portion of their breast, and management of the lymph node surgery. So really, any invasive type of breast cancer will have some lymph node surgery involved, whether I'm doing a lymph node biopsy versus doing a lymph node dissection. That's part of what I would do treatment-wise in the operating room as well.
What time do you wake up?
So I get up at about 5:30 every morning. Some days it'll be 5 a.m. It depends if it's a far clinic site or OR site. But generally I'm up 5:30 every morning. And if it's a surgery day, surgery starts at 7:30 in the morning, which means I need to be in the operating room, seeing the patient, talking to the patient by 7 a.m. And if it's a clinic day usually starts at 8 a.m. So I'm in the clinic ready to see patients by 8 a.m. And so today was a surgery day. So I was in surgery all day. So I got up at 5:30, got to the hospital by 7 a.m., was talking to the patient, consenting them, basically reminding them what we're doing today and getting legal consent for their surgery. You also mark the patient. I have to mark the patient. My first case today was a lumpectomy on the left side. So I have to go ahead and make sure I put my initials on the patient's left side to make sure that we do the correct site surgery, right? That would be no fun if you do surgery on the wrong side. Usually doesn't go so well. And so you got to mark the patient, do consent, and then the patient, we will them into the operating room. I do their surgery. I talk to their family after surgery, then go and get the next patient ready. See the next patient, consent them, and kind of do the same thing. Today I had 2 partial mastectomies or lumpectomies, and I had 1 total mastectomy. 2 of the surgeries were for breast cancer, and 1 active breast cancer, and 1 was for a high-risk lesion. So a lesion that has about a 30% chance of developing into breast cancer in the future. So it was a lumpectomy to remove that. And so after that, I went back to the office, probably finished around 2:30, 3 o'clock, and went back to the office to do some calls, some patients, follow up on some labs and imaging results, and was home probably around 4:30, 5 o'clock. So generally, majority of our patients are outpatient surgeries. And so most of my patients go home the same day, even mastectomies, even a bilateral mastectomy, for the most part, will go home the same day. Obviously, depending on the age and comorbidities and things, the patient may stay for that. But really a lot, if not majority of breast surgery now is outpatient surgery, which is really nice. I don't really have a huge inpatient volume almost ever.
Right, which makes it a really nice compared to like trauma surgery or something like this, maybe a
Yes,
little better lifestyle, right?
yes, night and day.
Right.
Yes.
So do you take call? Like, are you on call for your group, or and
Yes, we
what does
do.
that look
Yes,
like?
we do have a call schedule. And, obviously, if there's any emergencies and things like that, that we'll have to assume. But for the most part, there aren't really many emergencies in breast, as you can imagine. The biggest would be basically a post-operative, like a hematoma that you'd have to take back. And that, I mean, happens a few times a year. You can count that on one hand. So for the most part, there are not any acute surgical emergencies in breast. Now, with that, there's a caveat, right? The emotional burden of breast cancer is an emergency to patients,
Right,
okay?
right.
That to them is an emergency. And they will message and all this, and you'll say, you have to walk them off the ledge. They don't understand that this is not an emergency and it can be dealt with tomorrow. But in their mind, if that question or that whatever is not answered today, their cancer is going to triple in size by
Mm.
tomorrow. So it's an emergency. So there's that balancing. I may not have OR emergencies as much, but there's
Right.
a lot of emotional balancing of patient expectations given such a emotional disease process.
So one of my follow-up questions is, as a surgical oncologist, and again, like you said, that the patient's having a biopsy, they're being told they have cancer, they're coming to you and being worked up. I got a book in medical school, as I think a lot of doctors do, called How to Break Bad News. And I remember reading the book, and I think about the book because I have to give people bad news at times, and I always feel like I'm doing a bad job. And again, there's two like levels to me of bad news. There's bad news, like you're saying, you have breast cancer, but we can remove your breast or we can remove the lump. So yes, it's terrible, but I can fix it. And then there's like the really bad news, which is okay, you have breast cancer and I just imaged you, it's widely metastatic, and maybe it's not estrogen receptor positive and it's not a favorable lesion. Like it's really bad news. How do you feel about that? Like, do you feel like you've gotten better at giving bad news over the years? Is there such a thing as being good at giving bad news? Does that just take a piece out of you when you give it? How does that go?
So there's no such thing as being good at giving bad news. And for anyone to say that they're perfect at it is a lie because every situation is very different. Even if it's the same diagnosis and it's the same treatment options, it's a different patient. So no two situations are going to be the same. I'm just going to give you a little bit of a backstory. So as we've discussed, I used to do trauma surgery. I was doing trauma surgery and decided to go back to fellowship and do breast surgical oncology. And I've given bad news in both situations. I've had to give bad news in terms of, hey, this is a GSW to the chest and your son has passed. We did everything we can, or we've lost the baby. There's a GSW or a fall or a blunt force trauma and there was a car accident and we've lost fetal heart tones, etc. So there's bad news in an acute setting and then there's bad news in a chronic setting. So, what I found in terms of managing each one is that neither of them are easy. When someone is actively dying, that is a huge amount of stress, cortisol, et cetera, are rushing through that it's hard for people to really take in that information because there's so much emotional, like a high intense emotion going on because this is very acute, like in a trauma setting. And in those situations, there has not been time to prepare or think about it. Someone gets shot. No one was knowing that they were going to be shot for the last 3 days. No one got a call a week ago with a diagnosis of being shot, had a week to deal with it, a car accident, etc. So the amount of shock and all that kind of happens when talking to the family, it's almost like short-lived because it's all hitting them at once versus when I'm dealing with patients with more chronic disease, like a cancer, they have had time for whatever period, 24, 38, 48 hours a week to think about this. And it actually has been oftentimes something that they start discussing with others. So there's time to have conversation about it. And there's time to start to really grasp concepts and look into it, right? They can do their research. So when people are getting bad news about a chronic disease, it almost hits them worse because they know it lasts longer versus something that's acute was so quick when it happened that okay, you broke a leg, you know that leg will probably heal, it'll take a few months, but we can almost put a time on it. Acute things happen acutely and oftentimes can resolve acutely. Unfortunately, in the trauma setting, sometimes the acute resolution was death, but acute things happen acutely and can resolve acutely. Chronic things oftentimes don't happen acutely. It's acute in the situation when they found out about it, but cancer didn't just happen overnight. And then dealing with it is a more long-term process. So what I find is that it's almost harder in the patients with these chronic diseases because they know, oh my goodness, this is going to take the next 6 months out of my life or the next 1 year out of my life versus I broke my leg, I'm going to be off of it for 6 weeks and I'll be back on.
Right.
So the planning and the emotional turmoil that happens with chronic diseases, not to say it's one's better or worse, but it's a lot of times very hard for patients to come to grips with because of how much it's going to affect their life and their family. And when it comes to breaking the bad news, that's what oftentimes happens. Most of the time in these situations, it's the patient and their family, their parents, their children, their significant others, siblings, whoever, but it's a lot of people that are affected by this at the same time. So when I'm having to break news that oftentimes the good thing is most breast cancers are diagnosed in early stage because we have such great screening programs. Screening programs don't prevent cancers, they just help us diagnose them earlier. And so they're more treatable. So most breast cancers, when I'm talking to patients, are very treatable. More than 2/3 of breast cancers are in the first 1 or 2 stages and have a great prognosis, over 90%. But then there are the really bad ones, so that we were talking about, the really bad news, the ones that you're now metastatic, and this is, not going to be curative. So those patients, when I'm having to have those conversations, it takes a little bit more of a gentle stroke or a gentle spoon that you have to feed the information to. And I try and avoid information overload. I don't like to give definitive numbers because we don't give definitive numbers. The worst thing that you can do as a physician is say to someone, you have 6 months to live, or you have 3 months to live. We've all seen those TV shows. People write, the doctor told me I had 6 months to live. And I was like, I hope they didn't really do that. Maybe that's what the patient took from it. We can give general numbers and we can say the prognosis is this, or this is what a survival rate looks like. And we can give data, but never tell a patient that this is what you have, because we don't have that. We don't know that. And we don't have that power ultimately, but we can guide the patient in terms of being able to make educated decisions. So if this is, for example, was like a pancreatic cancer, we know that the prognosis of a pancreatic cancer is very, very poor. So for someone to say to someone that was diagnosed with pancreatic cancer, oh, you'll be fine, this is going to be like the flu and you'll get it over it, that's not accurate, right? But to also just say to someone with pancreatic cancer, you have 1 month to live, not necessarily accurate either. So it's to give them that accurate information. So break down the news in something that's factual and palatable, but also be soft while doing it. So there's no great way to do it, but I think the key thing to take away from when you're breaking it to patients is be objective and listen to the patient, listen to what their concerns are, and see if you can help ameliorate some of those concerns by giving them factual numbers and giving them data to work with and not conjecture. That would be the best way, I would say.
Your answers are spectacular, by the way. Like, I think everything you say, I want to go back and listen again. I want to go into nice things, but I always think the tough questions are sometimes tough. So I'm a gastroenterologist. So I do procedures, which is cool. And I love what I do, but sometimes things go bad or sometimes things go wrong, even when you're doing everything right. And as a proceduralist, you have the complications. My best friend is an interventional cardiologist, another medical doc who does procedures. And his job, I think, is much cooler than mine. But I'm an office gastroenterologist. I'm doing screening colonoscopies. Like, stuff happens, but not that often. And for him, again, he's a great interventional cardiologist. Things don't happen that often. But when you're putting wires in somebody's heart, obviously stuff that happens is, sometimes worse than stuff that may happen to me. So the jobs always seem like glorious, and people are like, oh, I want to be a surgeon. I want to be a proceduralist. I want to do these things. But things, can happen. So can you talk a little bit about just the stress, specifically you're, a trauma surgeon, stress of things going wrong as a trauma surgeon, and then as a breast surgeon?
That's a great question. That we are humans. And I think we have to remember that at the end of the day. And we are humans treating humans. And so not only are some things just out of our control, but some things are just kind of bound to happen. So I think one of the best pieces of advice I received when I was in residency was that understand that you need to do your best And then sometimes your best is not enough and it has nothing to do with what you did. Because sometimes it's very easy for us to take those complications and take them very personal. Like, oh my God, if I just done this or if I just done that, or you dissect everything that you do. And you should do that. A good surgeon should never be comfortable and be like, I was perfect. You should actually, that should be your first immediate response, to dissect everything that you did and make sure that you didn't miss something or not see something. Then after you've done that, give yourself some grace to say, okay, I have done everything possible. This was just going to happen. An example, just a very recent example, just this week, I had a patient who I did her mastectomy surgery last week. And she was great, young, early 40s, otherwise healthy patient. Obviously, being diagnosed with breast cancer in the early 40s was very scary and things like that to her. Did her mastectomy, she did great. But the patient has a history of unprovoked DVT a few years ago. And so in her pre-op, right, I talked with her hematologist and they said she needs to go on therapeutic Lovenox like 2 hours, like right after surgery.
Right.
So of course, yes, that's exactly what a surgeon wants to hear. I've got to put the patient on a blood thinner right after I operate on her. I made that cavity so dry. I promise you, there was not, it was like a desert. It needed water. It was so dry. Okay. So I get a call from the patient on Saturday morning. Hey, I think my drains are not kind of working and things like that. And then, I kind of walk her through things. And then she's like, okay, they're working again. I'm good. And she started her Lovenox on Friday. I did the surgery on Friday, started Lovenox Friday evening. And so then she had just one dose on Friday, though. Then by Saturday, she had two doses. And then now by Sunday, she's now dose 4 and 5. So around 4 p.m. on Sunday, she calls and it's like, my breast that's gone now because of a mastectomy, my breast looks like it's a balloon. Is this a problem? Yes, please go to the ER. Essentially, the patient had a huge hematoma. And at this point, a hematoma starts to compromise the skin. And so you can really have loss of the skin. It was a skin sparing mastectomy because we want her reconstruction to look good. So my concern now is not only is the patient bleeding, but also we may end up losing her skin, which would be very detrimental to her cosmesis and what the patient sees as herself. She wants to see some resemblance of normalcy after this. So either way, got her surgery done, and I just felt so bad, but there was literally not a whole lot we can do. So what do? Do I risk hematoma or risk DVT and PE? Kind of like you're stuck between this rock and the hard place. Like, which one's worse? Skin and have a hematoma or get a DVT, PE, and then die? And remember, she's also a cancer patient, so she's also high risk for blood clots. So sometimes you're just not going to win. So poor lady. And so again, that's just something that's going to happen. I couldn't not put her on the Lovenox. I had to. So obviously now we washed her out and everything like that, was able to save the skin, which was great because, we recognized it quickly, got her into the OR. But now she's not going to be on the Lovenox because she's obviously a bleeding risk. So now each day I call her, I was like, have you been walking? Are your TED hose on? You know what I mean? Because like, I don't want you to get a DVT and then a PE. So it's like, I don't know much else I can do. But what I'm doing is I'm advocating for her by calling her each day. Each day I call her and remind her, have you walked today? Have you gotten up out of bed? She's like, yep, today when I spoke to her this evening, she's like, yeah, I'm out walking right now, doctor. I only sit down for 10 minutes and then I get up and move again. I said, you go, girl. Until we're out of the woods, you go, right? So that's how you figure out a way to deal with a complication. Sometimes there are going to be things that you cannot do and you cannot change. So I told you before, I was doing trauma before, and that was actually one of the big things for me that actually led me to leaving trauma. I found that I felt, and I still feel it's true, that I was able to save more breast cancer patients than I could trauma patients. After a while, I worked in an urban area where there are a lot of penetrating traumas, right? With trauma, we have blunt force trauma and penetrating. Blunt force are the car accidents, the falls, etc. And then the penetrating are the GSWs and the stab wounds, etc. And so there was a high preponderance of those. And what I was finding is that trauma itself is a disease. So all of the GSWs always kind of came in threes. And of course, I'm a black cloud, so I'm the one that's going to get the three GSWs that are here all at the same time. And you're like, which one do I have to go to first? And you're like, what's the blood pressure? Okay, there's a 60 over whatever. I go to that room first. So what I found was that the disease of trauma, I could not cure. And I didn't feel like I could actually impact it. I had to tell parents all the time, I'm sorry, but we've lost your 18-year-old. One of the hardest things for me was in one day, I had a GSW of an 18-year-old that did a thoracotomy on, was able to bring him back, and then got him up to the OR for him to die upstairs in the OR. Then in that same day, I think it was all part of the same kind of gang violence. So what would happen is there'd be one GSW, and then there's a retaliation GSW, and then there's a retaliation of the retaliation. So they always kind of come in threes. And so the retaliation of the 18-year-old was the girlfriend. So there was a young 20s, just a, HIPAA wise, young 20s, pregnant girlfriend of one of the gang members that was being retaliated on. That person was sleeping on the side of the bed closest to the window. So the pregnant girlfriend got all the bullets. And the person that they went to retaliate on got just a graze on the knee. So the night before was the 18-year-old that we lose. The next morning, this is now 6 a.m., not even really, the morning, 6 a.m., the young girl comes in and she was 6 months pregnant. And either way, we were going to try and do an ER C-section, emergency C-section in the ER and things like that, lose fetal heart tones. And then eventually the patient also died. So basically the baby and the patient. And so now I have to go tell the mom that you've lost your child and your grandchild, future grandchild, all in one. Just for there to be another trauma one, I have not even 10 minutes with that patient for another GSW to be coming in, the retaliation of the retaliation. And so it was just a disease. How many times do I get to tell the mothers and fathers and family members of young people? One was an 18-year-old, this girl was in her early 20s. And so I felt like these acute problems and with trauma, it's definitely, I'm good at trauma. I'm a very fast-paced person and I worked at like that. But I just felt at some point like I don't feel like I'm moving the needle. And I felt that I needed to do something that I could move the needle. I wanted to have the longer term relationships with patients. My relationships with these patients are so short term, like literally extremely short term, because a good number of the penetrating trauma patients will die. And so I felt that I wasn't fulfilled. So I wasn't doing what my heart felt good doing. My hands did great. People, the lives that we saved for sure. But the ones that I couldn't save, I felt like, man, for everyone I can't save, I feel like I can save 2 or 3 breast cancer patients in the same kind of breath. So for me, I did some soul searching. And then of course, COVID happened, right? And we had so much time to do soul searching because we couldn't hang out with anyone, right? And so all we could do was soul search. And so I just felt, for me, I said, I'm going to do breast cancer or take care of breast cancer patients, which was my interest before trauma. And so I said, I'm going to go back to what that true interest was, because I don't feel like I'm moving the needle in trauma. So with that said, I took a situation where I said, this is not necessarily complications. These are just things that I cannot fix. And as a surgeon, for me, I was like, I must be able to fix things. Not being able to fix things wears on you. And so I said, I want to go into something where I feel like I can fix those things and I can make a difference for those patients. So
I'm going to shift gears a little bit. We're going to do some DO questions. So you're at a very prestigious university and a very big name, respected university medical program as a DO. What is it like being a DO at an elite university program?
I think it's good. I guess we'll start with that. It's good. But I think that one of the biggest things that students and people kind of need to realize is that osteopathic medicine is fantastic and it's well respected. So DOs and MDs are the 2 types of physicians in the United States. So I work with other DOs at Hopkins. There are a good number of DOs. And I don't think like we kind of look at each other like, hey, are you a DO or you are not? I don't think that we have like a DO code per se. But of course, when I see someone's like initials, I was like, oh, yay. But like, I don't know that just by seeing them. So I do work with a fair number of DOs, not necessarily within my department, within my breast department per se. I'm the only DO, but I work with radiologists that are DOs. I work with emergency room physicians that are DOs and other specialties that are DOs as well. So it is nice to not always be the only one. And I think that people need to recognize, or students should recognize, that osteopathic medicine is well recognized. I actually have some patients who seek me out for that. Some of them have a misconception of what a DO is, so I do have to educate them on that. But a lot of people say, I wanted to come see you because you're a DO. And I've had other DO physicians, or my dad was a DO, or my mom's doctor was a DO, and I wanted a DO surgeon. So it's actually really nice that being a DO is very well recognized and respected now. Not that it wasn't before, but I think there was like a stigma or really misunderstanding or miseducation for what a DO was. But really, I work with other DOs, and I have patients who sometimes ask me what a DO is. A lot of them have already looked it up. So one great thing about, well, good and bad, but one great thing about the internet and people do their research. There are patients who've come and said that I said something that I don't remember where I said it. They're like, oh, I saw that you said this in this video. That I'm like, where is this video they're talking about? And so, like, not in a bad way, like something like that. They're like, yeah, you said that you need to get screened at this age in this video. And I was like, oh, okay, great. In my head, I'm like, I should probably know where all these videos are, but that's the beauty of the internet. So patients are very astute and they will look you up. So whether you're a DO or not, like they already know that for the most part when they're coming to see you. Heck, they probably know your favorite color before they've chosen to come see you. So it's really important to continue to like move the profession forward, but not to feel necessarily like a stigma or something, because patients do respect us as osteopathic physicians, and our colleagues do too.
My follow-up question, and it's just interesting based on personal conversations that I've had over the past month. So I have a very good friend named Jen who she's a internal medicine doc who I trained with. She works at a university center locally in New York. Her husband is actually, she's an MD. She went to a prestigious MD university. Her husband is a DO who went to a very good internal medicine program and became a gastroenterologist. So there's an MD and a DO. She knows I'm a DO. She actually listens to this podcast. She's an MD who's a big lover of DO or do not, which really I appreciate. Her son is applying to medical schools now. And we have these discussions about MD schools and DO schools and the pros and the cons of different schools. And one of her concerns that she has brought up is that she's concerned that if her son becomes a DO and decides he wants to go to work in a university program like her and her husband are now, that there may be some limitations in, say, becoming chairman of a department or something like that. So my question for you, obviously just an opinion and based on your experience, is do you think being a DO at a prestigious, and obviously you have colleagues that are at the university, they're doing great, they're obviously doing good work, but do you think that being a DO might limit your ability to, say, climb the ladder and be chairman or chief or some position like that?
Not necessarily. I don't think that being a DO should be seen as a lesser profession or as a lesser title. I think people are born DOs. Let me put it this way. So I think that there are certain aspects of being a DO that just make you a DO in terms of the way that we see patients, the way that we see health, and the way that we really think of the body as a unit, right? One of our major osteopathic tenets. So I think being a DO is something that you just kind of are, number one. Number two is obviously then you go to medical school and you get your degree. So I don't necessarily think that things will prevent you from getting to a particular position, because at the end of the day, it's how you show up. If you are a good doctor, you are a good doctor, whatever initials are behind your name. I don't think that having an MD versus a DO should impact that. I'm sure I would be naive to say that it doesn't at all, right? Just because of what people's perceptions are. And so I think if you do a great job and you are a great physician and you're a great surgeon or whatever specialty it is that you are, people will see that. And I don't think that will necessarily limit you in the ranks. For example, I'm the fellowship director for the Breast Surgical Oncology Fellowship at Hopkins. I'm a DO. And doesn't necessarily impact anything in terms of, no one said you can't be this because you're a DO, this and that. Some days I joke and I'm like, I don't even think people know that I'm a DO because I'm just a physician. I'm a colleague. And really, that's the way I look at things in life. I think the way that we show up and the way that we tell ourselves to show up is really important. And this is just a, little side blurb for the students and trainees that might be watching this, is that you define yourself the way you want to be defined. If you don't do that, then you're going to allow other people to define you for yourself. So, for example, I'm a woman and I happen to be Black and I happen to be a DO, but I'm a surgeon. So I see myself as a surgeon. I am a surgeon. I happen to be female. I happen to be Black and I happen to be DO. If you see yourself as a chairperson of a department, then that's what you are. And you may happen to be DO or any of the other, defining things that we want to put on ourselves in society. So I think it's really important to not necessarily put that limitation on before you even start. If you say, I may not be able to get to a certain place because I'm a DO, then you're not going to get to that place because you've already put being a DO in a box different than something else. So for me, when I hear that question or hear that conversation, and I'm like, you can do whatever you want as a DO. DOs have been physicians to presidents of the United States. So I just think that to say as a DO, there might be certain limitations. Yes, in reality, because of the perception of certain places or certain people, perhaps. But I think it's up to you as that person. If you feel that going to DO school is what you want to do and what's in your heart, then you do it and don't put any limitations on yourself and you can literally be whatever you want to be. I know that sounds like, one of those cheesy cereal box, whatever slogans, but I really believe that just in life in general. If you say, I can't do something, then you're not going to do it. Don't put a limitation on yourself or a brand or a label on yourself that you don't want. Be what you want to be and then do that thing. And if you are good at it and you do a good job, people will see that. That's what people see. People see the job that you do and the type of physician that you are and the character that you are, and not necessarily the title or the letters behind your name.
My little caveat, and I didn't want to lead you in your answer, but my part of the discussion with her, I don't think I say it half as eloquently as you do, but I echo everything that you said. And my personal feeling, again, based on my best friend who I just mentioned, who's chief of cardiology and runs a cath lab for a major university program here in New York. And he's a rock star, like you're a rock star. And I think he's judged based on his skill, education, and what he brings to the table, period. And it's recognized, and I don't think that half the people even know what his degree is, and he's very proud of it.
Exactly. No, 100%. I totally agree. That's why I joke. I'm like, being a DO is who I am, but being a physician is what I do. So I think that's how anyone should go into a situation. I wouldn't trade being a DO for the world in terms of, like, some people think if you could change, or it was like, no, I am a DO. The way I think, the way I see patients, the way I interact with patients, being a DO is who I was supposed to be. So that's why I kind of say, I feel like you just know if you're a DO. I don't know how to explain it. You know what I mean?
I
You
know.
just know.
We're going to shift gears now all the way back. So I want to focus about you and your journey. So can you start us off by telling us where you grew up, when you decided you wanted to be a doctor, and where you went to college?
I was born in Nigeria and I grew up in Nigeria till I was young, as well as Canada and Connecticut. So I would consider probably Connecticut my home state. That's where I grew up pretty much from about age 13 to, after college. I went to college in Connecticut at Central Connecticut State University, and I also did graduate school in Connecticut. I have a master's in biology with a focus actually in cancer biology, and that was also in Connecticut.
Perfect. So when did you decide you wanted to go into medicine? And then maybe when did you find out about osteopathic school?
I knew I wanted to be a doctor since I was 8 years old. So I actually knew I wanted to be a surgeon since I was 8 years old. I think I wanted to be a doctor maybe a little bit before that, but I wanted to be a surgeon since I was 8 years old. I don't really have people say that they had some enlightening thing that happened. I don't know what happens when you're 8 years old. I just know that before wanting to be a surgeon, the only other two things I even considered was marine biology. I really, really love that. I every year in Catholic school growing up, we had to do like a book report, and it would always be on either a dolphin or a whale. And I kept on doing it, and then the teachers were telling my parents like, "Hey, she needs to do something different." So one year was a dolphin. Well, so it was a dolphin, then it was a great blue whale, then it was a beluga white whale. They're like, there needs to be variety. These are all marine animals. And after that, I think I saw maybe Apollo 13 or something, and I wanted to be an astronaut for a brief period of time. My dad told me not all astronauts that go up to space come back, and I was like, all right, no. So then after that, I landed on being a surgeon. So I don't really have a great thing. Those are just the things that I've ever wanted to be, and being a surgeon was the one that stayed with me. I always really loved working with my hands. I think that was the biggest thing. I always loved science and always loved working with my hands since I was a young child. And anything that I could build or do or touch, that was so important to me. I felt like touching and being able to take things apart and putting them back together, that's what intrigues me. I wanted to know what was inside things. I would always take things apart. As an 8-year-old, wasn't the greatest for my parents because I would always take apart locks. So, I wanted to know like how all the things work, but I didn't know how to put the lock back together. So sometimes they'd come back and they'd open the door and like the door would like fall apart and I'm like, sorry. But other than that, my love for science was really just always anything I could do, touch with my hands, take apart, put back together to the best of the ability of an 8-year-old, of course, was what I wanted to do. So always just been surgery. In terms of what led me to wanting to be a DO. So funny story is in college, I have a friend, Teresa, and she was 2 years ahead of me in college. So we were pre-med and we're really good friends. We're still friends. And I was doing undergrad and did my master's. I had finished college a year early, and so I didn't really have necessarily great mentorship. So no one told me that you actually have to do your MCAT a year before the year you plan to apply. So like I finished and I was like, oh, then I had to study for my MCAT. And so during that time, that's when I went and did my master's. So I didn't want to just have a year off. So I was doing my master's and taking my MCAT and stuff. So during that time, I was like, I'm going to apply to schools. And my friend Teresa just started DO school. And I'm applying to allopathic schools and I'm like, what is this DO? So like I don't like what are you? And she literally could not stop talking about being a DO. And she's like, oh my God, you have to look into be DO and this and that. And I'm like, Teresa, I don't have time for this. You know what I mean? Like I gotta get my applications in and this and that. And so I wasn't applying to DO schools. I didn't even know what a DO was. And then she's like, listen, you just need to learn what a DO is, shadow a DO, and learn what they do and see. And so then I did that and I was like, what? This is what I'm supposed to do. I was like, this is what I'm supposed to be. So I went to school to VCOM, Virginia. So she told me, she's like, okay, when you're applying to DO schools, you need to apply to VCOM, like, where in Blacksburg, Virginia, where Virginia Tech, associated with Virginia Tech. And so I was like, oh my gosh, I'm not trying to go all the way down south. And of course, when you live in Connecticut, Virginia is down south, right? It's not that down south, but it's down south when you grew up in Connecticut. And so I did that and I came to visit and I was like, why have people kept this a secret? This is what I'm supposed to do. And I just felt like my interview went well, but also like everyone I met and talked to and the students, it was like a family. It literally was like, this is what I'm supposed to do and where I'm supposed to be. Because my other interviews, they were good, but like I was like, this is just going to be school, right? I didn't feel like, oh my God, I'm going to love learning with these people. And that's how it happened. So I learned about osteopathic medicine during my application process. And I kind of abandoned I was like, done, done deal. And so I thank my friend Teresa till today for letting me know what a DO is. And she fallen in love with it. Because I remember when we were in college, we weren't talking about DO. We weren't talking about this. So she learned about what osteopathic medicine was during the process and then taught me about it. And now I teach everyone else about it. And so that's kind of how it happened.
Amazing. So now you're in med school. You already know since you're 8 years old you want to be a surgeon. Tell us a little bit about your application to surgical residency and how the match went or how you chose your program or how it chose you.
It's kind of the same thing. I am one of those people that believes that the universe sometimes just kind of tells us what and where, and you just have to listen, right? And sometimes if we don't listen, that's when when we're like, wow, I don't know why all this is happening because you weren't listening to the signs. I knew obviously throughout residency or throughout medical school that I wanted to go into surgery. Obviously, I made sure that I was in clubs. So I was, on vice president. It's no longer called SOSA, but at the time it was like the Student Osteopathic Surgical Association. But now it's a student section of the American College of Surgeons. But I was, I was like vice president of that surgery club. I did a lot of shadowing on my own. So I got to really work with a lot of the surgeons. And really, as a second year, I started doing that. So I started getting exposed to the surgical procedures. So it really helped me develop my skills early on. So when I became a third and fourth year, I was able to kind of maybe be a little bit ahead of some of my other colleagues or classmates. And I just put in a lot of effort and time. They say surgery, you got to be the first to get there, the last to leave, and all that stuff, which for the most part is pretty true. But because I actually loved doing it, I wanted to do it. One of my mentors in medical school is Dr. Steckel. He's now retired, but he was a very well-known surgeon in the New River Valley region and in the Blacksburg, Virginia area. And I told him, like day one, I was like, hey, Dr. Steckel, I'm going to be a surgeon. I just want you to know that. So I want you to treat me like, I said, don't take it easy on me. And he didn't, in terms of, he's like, so what does that mean? I was like, so if you get called at 3 a.m. for an appy, call me at 3 a.m. If you get called for this, call me. And he's like, are you serious? I was like, yes. And he did. And I literally I was assisting him on appies and things like that. And he taught me how to use laparoscopic equipment. He had an old set in his office that he would show us. So I felt so blessed that he kind of took me under his wing. So like I felt like I was doing, like I was learning intern level things as a third year medical student. And so really, because I really wanted to do this. And so I say put 2 feet in, right? Put all the effort in to something that you want to do. If you don't know what you want to do, that's okay too. Still put all the effort in to learn all the specialties, so that way you can make an educated decision. And in terms of getting into residency, so obviously I was doing a lot of things to get myself ready and look good when I go on the audition rotations, which the term audition rotation is a little bit antiquated. They don't use that term as much anymore. But essentially is when you go on a lot of places will call them sub-Is now, where you go on these rotations of places where you may want to do your residency to kind of show them what you've got. And so because while I was in third year and at the beginning of fourth year, I did another rotation with another surgeon, a vascular surgeon, who literally, I said the same thing to him. I want to do surgery, so treat me like an intern. And I was at the point where he was like, I made an incision. I made, like, we were doing a laparotomy or splenectomy, and I got to make the incision. So basically, that Dr. Downing is his name, vascular surgeon in Virginia. So either way, I got to learn and own my skills in third year and a portion of second year really well. So when I got to my fourth year audition rotations or sub-Is, I looked really good. So you have to prepare and you literally give your all. But I did all those things so that way when I went on these rotations, I would look good on the rotations. So one of my first sub-Is was in Toledo, Ohio. Again, I'd never been to Ohio before. Really leaving Connecticut was like the first, going to Virginia. And now I'm going to Ohio. Like, what's happening? And so I did a rotation in Toledo, Ohio at Ohio Health Mercy St. Vincent Medical Center. And I fell in love with the program. My first day on call was a gentleman who got stabbed in the abdomen by his neighbor with a samurai sword. And it was a trauma center. That's where kind of like my love for trauma kind of started, I guess, as well. And I just hit me and I was like, this is where I'm supposed to be. Like, people just like, first of all, just a side note, I said to myself, what kind of, like, you have to kind of maybe be a little bit annoying or not the greatest neighbor that someone needs to go grab a samurai sword. Because that's pre-contemplated. Like, if you think about it, right? It wasn't just like a kitchen knife, right? A samurai sword is somewhere upstairs in a glass container. You know what I mean? That you have to like go find the key. That is literally, that neighbor is probably like, the next time he says this to me, you know what I mean? Yeah. So anyways, that's just a side story. I just told myself, like, be a good neighbor. Never make someone want to pull out a samurai sword on you, right? So anyways, that was a night that I was like, this is the coolest ever. We're in the belly, we're doing an X-lap. And those samurai swords are really sharp, just in case anyone wants to know. And so I was like, this is where I'm supposed to be. The residents were great. They took me under their wing. One of them is we're still all really good friends now. Carrie and Chrissy were two of the female residents the year ahead of me, like took me out to dinner and we're, like it just, again, kind of like how DO school happened. I was like, this is family. I met the program director, who's one of my mentors and sponsors till today, Dr. Cashin, who my interview with her, I just, at the end of an interview, you're like, did we actually interview or did we just have a conversation for 2 hours? Like that, I was like, I don't even, like, what were the questions that we just talked. And it was fantastic. And she literally is a mentor till today. We still talk probably every couple of weeks. So I just felt like that was a place that I wanted to be. Did I think that I was going to end up in Toledo, Ohio? Had I ever even been to Toledo, Ohio? No, but that was the place that I was meant to be. So the universe sometimes speaks, and I think you just have to be open to things and just be fluid and flexible to see where your path may take you because it can change.
Amazing story. I love the samurai sword. It's amazing how these things, like, obviously that's profound, but it just stays with you.
Right.
You'll remember obviously that person forever. But getting back to the journey. So when you graduated, you can tell us about looking for a job and tell us how you ended up at Hopkins.
Yeah. So when I graduated, so during residency, I did a lot of research in breast. So Dr. Cashin is a general surgeon, but does a lot of breast. So, and she was my mentor. But then during residency, I also developed another mentor, Dr. Knotts, who was the chief of trauma. And so I had I felt torn, and I was like, breast surgery, trauma surgery, breast surgery, trauma surgery. And so when I was applying, I started the process of applying to fellowships during residency. And I went to Dr. Cash and I was like, okay, here's an application for breast surgery and here's an application for trauma. And so she's like, okay, are you confused? Like those are two very different things. I said, well, here's my rationale. I'm I'm very much like, what does the universe say I should do, right? So if I apply to both, I said one of them has an earlier application cycle than the other. So I'm going to apply to both and then I'll find out from one before the other, then I can cancel the other one. And she's like, or you cannot do that. And why don't you go out and practice and see what you end up liking or loving more. And that's literally exactly what ended up happening. I came out, I was doing general surgery initially, and then took the trauma surgery job, which I was doing. And then after, COVID and things like that, I decided I really actually want to go back and just do breast. So I kind of did both and found that breast is really what I love or love more. I love trauma too, but I think I love breast more. And also breast allows for a really nice work-life balance, etc. So it does do a decent amount of that compared to trauma. So during COVID, shortly before COVID, I started, but during COVID is when I was interviewing for breast surgical oncology fellowships. And I matched at Georgetown University in DC. And so that what brought me to the DC area. And I then really kind of fell in love with academic medicine. So I had done a lot of obviously trauma before that. And even my residency program was more it was a large program, but in a community setting. And that's kind of what I always thought I was going to go back to. But I loved research even in the community setting that I did a lot during residency. So I did a lot of it during fellowship and teaching residents. And that's something I've always loved. So doing academic medicine kind of became what I realized that I was supposed or needed to do. And so I stayed in the area and I joined the faculty at Hopkins.
What a journey, right?
Yes, yes.
Thank you so much for sharing your story with us. It's truly, truly inspiring. I love everything that you've shared. Our last grand finale question is, can you give us one piece of advice that you were given from someone else that you found inspiring and would like to share with our listeners?
Something that I learned during residency, and I was told this by a trusted attending mentor figure, that you always have something to learn. Always have something to learn out of any situation. Sometimes something bad can happen or there could be a bad interaction. So for example, there may be something that an attending does that's not so great because we're all humans, and or treats you a certain way or speaks to you in not a great manner or things or didn't handle a situation so well. And so when you're faced with how do you deal with that situation, you can learn from that situation. You can also learn what not to do from that situation. So what I was told by this attending that gave me the information or this great word piece of advice is that you can always learn. Even bad situations teach you lessons. And sometimes it's not a lesson of what you should do, but a lesson of what you shouldn't do or how you don't want to be for the next person. So if someone doesn't treat you a great way, because surgery is hard, right? Like surgery is tough. It's not easy. Really, medicine is hard in general, but surgery is tough. So there could be an interaction or something and someone doesn't treat you the best. And you can take that in your chest and say, oh my goodness, and be really sad about it and this and that. Yes, we're humans. Get sad about it, do whatever, get it out of your system. But then at the end of the day, say, how am I going to learn from this situation? In the future, if I ever have a trainee or someone that I'm teaching that does this or whatever, I am not going to treat them this way, or I'm not going to do this. So even in a tough situation, you can learn how you don't want to treat someone else in that situation. So it was such a, when she told me this, I was like, oh my gosh, I am released. Like I feel better about the situation. This individual said something that was not kind and was not good, but how do I want to deal with that situation? So it was a really good lesson, just really in life, to remember to take your own temperature. You respond to things only the way that you respond to them. So there could be external situations, external factors, but don't ever let them change you and make you do something or react in a way that is unbecoming of yourself. So that's what I learned in that situation. The mentor person speaking to me said, well, how do you want to handle this? They said, you can do this and you can do this and you can take it to this stage and, do this about it, or you can learn from it in terms of maybe just take it as a learning lesson for what you don't want to do to someone else in the future. And that's what I decided to do for that situation. And so I could have reacted or done something in response to that. But if you take your own temperature, you can control your own response to any type of situation.
Spectacular, spectacular advice. I would say definitely top 10 advice. Your time is valuable, obviously. You're awesome. I really
Thank you.
appreciate the conversation and your time, and I'm sure our listeners will love every minute of it.
Thank you.
This concludes our episode of Do or Do Not. Send all inquiries, comments, suggestions, and even let us know if there's someone you want us to interview to doordonotpodcast@gmail.com. Don't forget to like us on Facebook at Do or Do Not Podcast for updates. If you enjoyed our podcast, please share it with your classmates and administration. We have plenty of more interviews lined up, and we're excited to share them with you. This is Tian Yu Shea. Thank you guys so much for listening to Do or Do Not.